Hi, everyone. Thank you for being here today. I'm Tandra Garvin, a dual certified nurse practitioner in acute care and psychiatry, and I'm excited to share a project that's close to my heart. It's called Behavioral and Psychological Symptom Strategies for Managing Dementia, and it's all about helping caregivers manage tough behaviors without jumping straight to medications. So when I say tough behaviors, I don't know if you're familiar with dementia patients. Sometimes they can have agitations. So there's things like hitting, yelling, um, wandering. So these are the symptoms that I mainly help educate caregivers based on the current data and literature that is out there to manage these behavioral symptoms so that we can reduce the amount of medications we use on the memory care unit. Before I get into it, I want to take a second to recognize some special people who made this possible, who helped me with this project. My chair, Dr. Teresa Gallicados, she supported me from day one. She's been patient, very supportive, and encouraging, and she's always helped me stay on track. Our instructor, Dr. Rachel Davis Citron, thank you for your focus and your feedback and helping me sharpen my skills. And my community person. She's been very valuable throughout this all. She brought an educator's perspective that reminded me just how powerful proper training can be. I'm grateful for each of you for being with me on this part of the journey. A little bit about myself again. I'm based out of Phoenix, Arizona. I got my BSN and MSN from Grand Canyon University. I went back to complete my postmaster's in psychiatry at Maryville University, and here I am still completing my DNP at Maryville University. I'm certified in both acute care and psychiatric mental health. I love what I do, and I'm passionate about taking care of our aging population with dignity and intention. So, about my project. So, did you know that there are about 6.9 million Americans over the age of 65 living with Alzheimer's dementia? That number is only going to go up. And one of the hardest parts of dementia care can be managing behaviors, things like I mentioned earlier, aggression, restlessness, and agitation. A lot of times, the default is to prescribe medications, mainly antipsychotics. Both those meds, antipsychotics or antidepressants, these meds come with risks. They can cause orthostatic hypotension, which means lower the blood pressure, which increases the falls in our elderly patients. It can even sedate them, and it can lead them to respiratory depression and early death. So this project came from a simple idea. What if we give caregivers the tools to handle the behaviors in a different way? That's what led me here today. So the purpose and the aims was to help to reduce the antipsychotics in dementia care, also to introduce non-strategies that staff can use right away. I wanted to improve outcomes for patients and staff by giving caregivers confidence and options. The question I asked was, my DNP question is, if we educate healthcare workers on non-pharmacological strategies, can we reduce how often antipsychotics are used for behavioral symptoms in dementia? It's a simple question, but a very powerful one. I use the Plan, Do, Study, Act. And many of you are familiar with this probably from doing your research for this project. It's a great quality improvement model because it lets you test, adjust, and improve as you go. It helped me keep things realistic and flexible in a busy care setting. I looked at the research and the message was clear. Antipsychotics can be dangerous in dementia care, but non drug strategies like redirection, music therapy, routines, and validation can be just as effective with none of the harmful side effects. What's also clear is that staff education matters. When caregivers are trained and confident, outcomes do improve. I used the mixed methods approach, which means I looked at both numbers and real life feedback. This memory took place in a 30-bed memory care unit. I did get the IRB approval through Maryville, and the project was run over 4 weeks. And staff was trained on how to respond to behaviors using practical hands-on techniques. And a lot of the data that I got, I mean, a lot of the education interventions I got, I did attend some Alzheimer's conferences, and I also used the website that was designed uh, to help caregivers with Alzheimer's patients. Along with there was several other journal articles where this research had been performed as well. So I use escalation sheets. We track escalation events, survey the staff's confidence after the training, and review medication logs to see if antipsychotic use changed. And this was when I say escalation events, every time a patient was, had a behavior, maybe like agitation, hitting, yelling, um, the staff, checked off a sheet to show what interventions that they used. And then I'm the psychiatric nurse practitioner on the unit, so I was able to, attempt to do dose reductions and to, I had it really a close part of managing the medication. So, where we were able to titrate down some medications, that was done. Caregivers also completed daily logs to reflect on how things were going. Their words were so valuable to me. A lot of the caregivers were very enthusiastic about how some of these approaches worked. Descriptive statistics on confidence levels was used, and we also used the chi-square testing to look at escalation events and medication use. And thank you to our statistics person who actually helped me come up with this. The qualitative part where we analyzed staff comments gave us context and helped us understand what was really going on behind the scenes. So the results were as follows. The confidence scores did go up after training. The average caregiver confidence was about 4.02 out of 5. So it was a little improvement. There was really no big improvement with the escalation events. No major change in a 4 week window. However, I do feel that if I maybe did this project over like 6 months, I could have saw some change. Um, so while the numbers didn't move much, confidence did, and that's where change ultimately starts. Caregivers said things like, I feel more confident managing difficult behaviors. So these are my scores from the training and the pre and the post training. So caregivers said they felt more confident managing difficult behaviors. And a lot of times, a lot of the feedback I got was like, oh, I know what to do, but when it's busy, it gets really hard to put that into practice. And then sometimes some other remarks I received was sometimes I just react because I'm overwhelmed. So what I found out is that the caregivers, they want to do better, but they also need time, support, and more hands on deck. But that's another story, right? This is some of the slide just shows some of the qualitative feedback that I did get. from the staff, the caregiver staff. So the biggest takeaway for me is that education really helps. So the confidence did go up, but applying it consistently, especially during stressful shifts, was hard to do. This tells us that education alone isn't enough. We have to make the environment better too. Reduce the workload, improve staffing, and keep reinforcing what was taught. And I think that's big for me. It's like not to let all these behaviors, these changes go by the wayside. It's, to be a champion on the unit and, keep reinforcing that we are making change and that we are prolonging these dementia residents' life by not, by doing this redirection and not having to prescribe medications. So interpretation of results. Um, this is just one unit, so we had a small sample size, and the intervention lasted about 4 weeks. So there was not a lot of time to show, major medication changes, but it also gave us a foundation to build upon. So the results that I got was the increased caregiver confidence in managing difficult behaviors. Practical application remains a challenge. High workload and stress can hinder consistent application of learned technique. So, like I said, that's where it comes from, me being constantly as a change agent. It's just being there to support and reinforce, some of these techniques so they won't go by the wayside. And the discussion of the limitations, again, we had a limited size. So it was a small sample size. And then during the busy work days, it was just kind of hard, like to, people were just focused on their task and doing their job. So it was just kind of hard to put these practices into place. So, like I said, I think if we would have had a longer time span in 6 months to a year, I think that would be better. So, my goal is to make training part of onboarding. We discussed this with the leadership there that this training will be part of onboarding, and we'll keep it going throughout the year. So this program didn't just die, just because my school is over. We're going to still keep these things going. So things that I came up with leadership is we're going to have some visual cues around posters, and then do short refreshers like at team meetings and also at before the shift starts, when we have the huddles, we'll keep these practices into place. And I would like to see, and I will look into seeing how I can push for policy changes that can support this kind of education with real funding, right? We can't expect caregivers to use new skills without supporting them along the way. There was many benefits to this approach. So the implications were ongoing education, caregivers felt more empowered, um, and staff actually collaborated better. And it aligns with dementia care best practices, less medication, and more person centered care. So, once again, the benefits were enhanced caregiver confidence, improved staff collaboration, and it aligned, which was big, with standards that reduce antipsychotic medication and emphasize person centered care, alternatives to medication when managing behaviors. So before I did notice when I was on the unit, it was, the caregivers would quickly come up to me and say, you need to prescribe Haldol or Seroquel or, Risperdal. But now I do notice that, they will come to me and say, you know what, we tried XYZ, this isn't working. So maybe you can look at prescribing something that's helped this patient calm down. Where, like I said before, it was like they wanted me to just go straight to prescribing. So I do appreciate that this project has helped him to kind of think outside the box. Education interventions are valuable. Recognize caregiver skill development, and also recommend we're going to recommend sustainable training programs and leadership support. Education is an ongoing thing, and the leadership also talked about ways that um, support can be given to caregivers, especially when they're short-staffed or overwhelmed. And the big deal, I'm so grateful that leadership got involved, and this also showed the caregivers too that they had someone had their back, right? And we know that culture change takes time, but it's definitely worth it. I want to thank you guys for listening to my hard work today. This project reminded me of why I do what I do and how much caregivers really truly need their support. I love to hear your thoughts, questions, and feel free to reach out to me at any time that you may feel like it at my email. And I'm very excited about hearing about all your projects. And this project just opened up something so deep for me. It was I want to just keep the momentum going, and it's keep the education going, because being at this level, it's easy to it's about making the change. It's before, I know it was like when I was a RN, I would say, oh, complain about things. But now at the level that I'm at, it's like, what can I do to see better change? So I just thank you, and for listening to this, um, my hard work, to hearing about this project, and thank you guys again.